Hello, and welcome to the panel discussion session for the Heartburn and Reflux and EOE discussion panel from the 2021 Norton Educational Series Anniversary Edition. Today we have with us our four speakers who you just heard give their stories. Louise and Eric, thank you so much for doing that. And also we had two experts in the field give us some background information about EOE and heartburn and GERD. So today we're going to have a discussion with these wonderful panelists and maybe answer some of those questions that came up during the meetings and talk a little bit more about what we heard in those videos. Earlier, you heard from Dr. John Pandolfino. Dr. Pandolfino is a professor of medicine and chief of gastroenterology and hepatology at the Feinberg School of Medicine at Northwestern University in Chicago. Dr. Evan Dellon is a professor of medicine and adjunct professor of epidemiology at the University of North Carolina School of Medicine in Chapel Hill, North Carolina. Dr. Dellon is also the current director of the UNC Center for Esophageal Diseases and Swallowing and serves as associate editor for clinical gastroenterology and hepatology. The two patients that we heard from today are Luiz Yamashita, who is from Mount Pleasant, South Carolina, and has a family history of acid reflux, not only with himself, but with family members as well, and was so generous to share his story with us. And also Mr. Eric Taylor, who lives in Pennsylvania, who has self-managed and finally was diagnosed with EOE and shared with us his story as well. So we're going to have a nice conversation with these four gentlemen and talk a little bit about tips and tricks and also some things that you should know at home to help you on your journey. So first, one of the things I wanted to talk about today was the whole issue around the delay in diagnosis. Because both of our patients, Louise and Eric, both of you medicated for a while. Louise, 5 years, and Eric, 16, 17 years before you had that final episode that really brought you to the hospital and got you a true diagnosis of your condition. Louise, can you tell us a little bit about why you just managed for 5 years? Why didn't you talk to your doctor? Or did you and not get results?
I think that's a problem that all men have. We don't want to go to the doctor, right? So I'm sure the doctors hear that a lot. And, it quite honestly, it is something that you don't think about it because you never think it's going to be that bad. Just like a heartburn, which everybody complains about it. You always see commercials on TV. You take this, you take that, it will control your heartburn. But what people don't realize, what I did not realize, was that, the recurrence of that, acid reflux over a long extended period of time was actually damaging my esophagus and also my stomach, So when I did my endoscopy for the first time after a long time, we were looking at the esophagus, and the esophagus was so inflamed that was probably similar, to what you had as well, where the walls were, it could have collapsed. I didn't get close to that, but it was, to a point where I forget the number count, but let's say 15 was the number that would put me on E&E. I think I was like 12, so something like that. And then I had a polyp on my on the junction between my esophagus and my stomach that was growing, and it could have blocked, completely the food from going down because it was blocking maybe 50, 60%. And I think that not knowing that this is such a serious condition, that can start very, very quiet, you don't notice as often. Maybe you just kind of, brush it off and say, this is okay. I'm just going to take some Tums. And, Tums never really touched that, for me. And it was never something that helped me a lot. It helps for like 10 minutes. And after that, it's pretty much, you're back in the situation where you were before. And, but the prolonged time that I waited, I think that just caused it to be more concerning. And I wish I had known that, you could get to that level, because, I would have addressed this a lot earlier. And I was going to say to you, after I started taking omeprazole, I think we did 40, initially to try to bring it down. I did another endoscopy and everything looked fine, So I wish I had done this a long time ago and not have to have suffered through the process of, eating every time and feeling, that there was a discomfort there. So, and one thing that I did talk to my doctor, my general, practitioner doctor, he said, your stomach is very sensitive. If you have a stomach cancer, usually those are very, incurable in general. So he said, be careful what you decide to do. If you decide not to take the medicine, just be mindful of that. And once he told me that, I said, you know what, I'm not gonna fight my weapons off. I'm gonna take it every day. It is what it is. It makes me feel better. I rarely have any issues now. Maybe once a year I'll have some discomfort, but it's probably because I forgot to take my omeprazole, or I did it and I had to eat right away, whatever reason it was, or maybe I ate too much of something that usually causes me, discomfort. Chocolate in general messes up with my stomach. So I would say that was one of the reasons, that made me even think more about staying on that regime of, taking my medicine on a daily basis, which now it's almost like brushing my teeth. I do it, without even thinking about it. I wake up, pop the pill, 30 minutes later, we eat. Sometimes I'll go an hour later and I'll do it. And, that was just an eye-opening situation for me.
Okay, thank you, Luiz. And that brings me up with all kinds of questions. But first, let's move over to Eric. Eric, so I know that's a long time to have this choking feeling. What hindered you, or did you go to the doctor? What was that like?
I think like Luis had talked about, like it was mainly like, okay, fight through just the little things and see if you can manage daily without going to the doctor. That was kind of like my mindset in the beginning, and it was also combined with being in Europe. So I was in Europe from like 2000, from 1998 until 2010. And in Europe, of course, has unbelievable doctors there. But I was like, okay, well, this is only happening once or twice a year. Is this severe enough? And of course, I wasn't as educated at that time about the EOE, had no clue about EOE. Is it severe enough for me to go to the doctor and say, like, okay, well, I choked on my food at dinner in June of 2001. I didn't choke again until December 2001, and then I don't choke again until December 2003. So it was like for me, in my own experience, it was those intermittent issues of the choking, and thought that, okay, I didn't chew my food right 6 months ago. Oh, and then like, okay, I forgot to chew my food right this time. Oh, okay, I've been chewing my food right for 2 years, and I'm okay. So that was kind of like my thing. It totally brushed it to the side. Didn't think there was anything serious until 15 years later, in 2016, I was starting to get this super severity. Like it was like choking nonstop. Where in order for that bolus to enter the in order for it to enter the stomach area, it took like 10 minutes of trying to either push it down with water, or I would, try to stick my finger in to try to make myself throw up. And so I started to tell myself, like, I need to go to the doctor. Something's going on here. And I still didn't go because it was like once a year still. But even though it happened once a year, in order for the bolus to get down, it took more time. So, like Luis's story, the esophageal walls became so closed and so constricted. And Dr. Huda, who did the surgery in September 2017, he told me when he went down there, they couldn't get a pediatric catheter down my esophagus. They couldn't get a pediatric one for a child. And he basically said my esophageal hole was like this instead of like this. And so when he said that, I'm just like, wow, okay, that was it. And to answer your question, that was one of the reasons. It was like super spread out as far as my choking issues. They were spread out. They weren't like once a month, twice a week. It was like once a year, or 2 times a year, and then what happened for 2 years. And that's one of the reasons why I didn't go to a specialist that was educated about gastrointestinal
Yeah, Yeah, that makes sense. But Dr. Dellon and Dr. Pandolfino, I mean, I understand his logic, right? That's not happening very often. At what point do you think this is something he should have mentioned to his doctor? At what point should someone start thinking in the back of their mind, maybe this is not just me not chewing their food? Are there warning signs that people might know or to think about that would lead them to your office?
I don't know, Evan, if you want to take it, but for me, I think, when you have trouble swallowing food and something, you feel like something's getting caught, that's a warning sign unto itself. That's something that really should prompt an endoscopy and really a look. Now, you can make the case that if you know that you were out to dinner, you were chewing your food not so well, and had a little bit of discomfort and resolved very quickly, maybe that one time it never happened again, then yeah, you probably. But I think after the second one, definitely, I think getting an upper endoscopy would be key. But that's one of the warning signs for us. If you have pain when you swallow, or you feel like a piece of food gets caught in your esophagus, that's a knee-jerk reflex. You need an upper endoscopy to make sure it's okay and everything's fine. And upper endoscopies are very simple tests when they're done diagnostically. You don't want to do them when there's a food impaction, because when there's a food impaction, then they become difficult and then they become more dangerous. But if we catch you at that early time, we can make that diagnosis and treat you before you ever get any serious complications. So I would definitely, let the audience know that we don't want people to wait like Eric and Lewis. We want people to come in and get evaluated so that we could preemptively prevent people from scarring their esophagus and coming in the middle of the night, with a food impaction.
Yeah, I would totally agree. And again, I would just emphasize that trouble swallowing and the sensation of food sticking is not normal. And it's something that should get checked out. And I think, Eric, what's interesting about your story is you have clear recollections of these significant episodes where something is sticking and you know the date and the year. But I bet if I asked you, and you even said this a little bit, but what were you doing between them? My guess is you're eating really carefully, right? You're chewing slowly, you're taking little bites. And what happens, especially in EOE, is that over the years, people almost subconsciously adapt, right? You may not have gone out and had like a big hamburger on a crusty bun, well done burger, right? You would avoid that kind of food. And this happens, and it's a way that people, they don't, a lot of times aren't even aware of it. They're minimizing the symptoms. But you might, if someone was with you, they might notice, oh, you're drinking a glass of water after each bite. You're eaten 4 bites and I'm done with my food. And those are all subtle things, but I would say that it wasn't, oh, you had 3 or 4 episodes over 5 years. You had bad episodes, but on a day-to-day basis, you were doing things that minimized your symptoms. And that's also important to know. That's not, a normal thing. And some people, they may say, oh, I'm just a slow eater. And that's fine. But if it's, something where you're trying to minimize doing something to give yourself symptoms, that's even more reason to get it checked out for folks who are listening.
Mm-hmm. Mm-hmm. Totally agree.
Absolutely. So I want to pop back to Luiz really, really quickly. So Luiz, one of the things that you did say was you talked about being on your omeprazole, which is a proton pump inhibitor, which John described in his talk. And there's some concerns that we hear out on Google about taking these things long term. Can you tell us what is the truth of that, and what does the science tell us about that?
Yeah, well, that's a great question, because the ACG guidelines and INGERD were just published this week. And one of the things and one of the statements that they make is focused on the risk-benefit ratio of proton inhibitors. And really unequivocally, they were in support of using PPIs based on its safety record. The statement is essentially focused on stating that PPIs are very safe medicines. There have been these studies, and they clearly state this in the statements, that there have been studies that show an association with certain particular things like dementia, chronic kidney disease, cardiovascular disease. But even in the statement, they say these are flawed studies. And in the very well done prospective studies that were designed to look at side effects, there's no data to support that these side effects occur. So they really set the stage that people should realize that if you need these medicines, like Luiz and Eric, and when we talk about these kind of situations where you have stricturing and fibrosis and severe EOE and you're responding to the risk of stopping that medicine is so much higher than, the risk of taking that medicine. It makes no sense to advocate for that. Now, I will tell you that in my practice, you need acid to digest food, and sometimes people feel a little bloated on the proton pump inhibitor. Their bowel movements may change a little bit, and you can get around that by changing your diet a little bit, taking some supplements, most likely. Iron needs acid to be absorbed, and if you're found to be iron deficient, you can take a little bit of an iron supplement. You can get around that. But for the most part, these are very safe medicines. And we would never stop these medicines because of those theoretical risks that were really born out of bad studies. And we would focus on treating the symptoms and complications that you currently have. And I think that's most important.
And John, one of the side effects that you hear a lot is about osteoporosis. I don't know if you have any comments on that. That's one of the things that came to my mind when I said, do I need to take this on a prolonged time, to help me with my acid reflux?
Yeah, in fact, they address that also in the ACG guidelines that, osteoporosis is also not something that has been shown consistently to be associated with proton pump inhibitors. They're not even advocating in this ACG guidelines that you take vitamin D or calcium to support that particular issue. I think if you're eating a healthy diet, and getting good dairy and calcium, you have nothing to worry about. I do think that if you were in a very restrictive diet or had another GI problem that would affect your ability to absorb nutrients, and then you were on a PPI, maybe then you'd be a little bit concerned that you wouldn't be getting iron, vitamin B12, and calcium and so forth. But for the most part, if you're not, I think there's a very low risk that you'll have that mineral deficiency. And in my practice, I don't check for it. I think if people are eating a healthy diet and they're on a PPI, I do not look for those kind of problems.
Okay, that's good to know. Yeah.
Thank you. Yeah, that's fantastic. So I want to talk a little bit about the with the EOE. Dellon, just Dr. Dellon, switching over to that a little bit. So you mentioned in your talk about a dilation. So and Eric talked about his esophagus stricturing down. What exactly is that dilation? Does that hurt? Will the patient be medicated and asleep when that happens? And how does that help?
Yeah. So, a dilation is a procedure that's done during an upper endoscopy when someone is already asleep and under anesthesia. And it's done to treat an esophageal stricture and to stretch it out. And so in EOE, what happens is over time, all of the inflammation with the allergic cells causes the body to lay down scar tissue. And we know that in most people, though not everybody, over time the esophagus can develop scar tissue and get smaller. And like Eric said, his is an example of one end where it goes down to such a small little narrowing. A lot of the medicines we use and treatments we use for EOE now are very good at getting rid of inflammation, but scar tissue like that may not go away completely. And so if people are having trouble swallowing and there's a scar tissue or narrowing of the esophagus like that, then you do a dilation. And so what that is during the procedure, again, when you're asleep in the endoscopy, there are a couple of devices we can use. One is a balloon that can go through the scope that can expand carefully and stretch out that stricture. Another is a long tube that's kind of like a tapered device that can also stretch out the esophagus. And these have lots of different sizes, so we can customize the size for each patient. And it can break up some of the scar tissue and start to open the esophagus. The real benefit of this is almost immediately people feel better, like their swallowing is improving. And it's a procedure that it doesn't add a lot of time to the endoscopy, And in general, it's very safe. In the early days of EOE, we worried that it would cause a lot of complications with tearing of the esophagus or even perforation, which is getting a hole in the esophagus. But we've learned over the years that this can be done quite safely and that most people do very, very well with it. Now, I will say that the large majority of patients are sore after their dilations. And this is very, very common with EOE. People tend to have a sensitive esophagus. And so knowing that you're going to be sore, it helps to expect it. Some people may need something simple like Tylenol to help with the discomfort. Many people may have to do a soft or liquidy diet for a day or two, and then they tend to feel better. Some people may need a little bit of a stronger pain medication, but in general, it's quite well tolerated, and then people tend to feel better with the swallowing. One other important thing to know about dilation is if you have a really narrow esophagus, you can't go from super narrow to larger to normal in one setting. And I'm sure, Eric, you experience this many times. We just go in very small increments to keep it safe over several procedures to get back to a more open size. And so that's also something to know, that if you have a stricture in EOE, you may need several dilations, and the strictures can come back over time as well.
So if the strictures come back, would you go in and dilate again?
Yeah, in a lot of cases you would. And there's not a rule for this. Some people, if the EOE gets better and the biopsies look good, all the allergy cells go away, there's people's strictures can improve and not need very frequent stretching. Some people, if the EOE is very prominent and more severe, the strictures may be tougher to stretch and may come back even with treatment. So there's a real range, and it's very individualized on how it's approached per person.
Awesome. And so with EOE, then it would be important to have regular endoscopies just to monitor if you're getting more strictures.
So we monitor it in a couple of different ways, but basically, yes. So the endoscopies right now are really required in EOE. We don't have any other ways with blood tests or other imaging tests to really know what's going on in the esophagus. But the amount of endoscopies and how frequent they are, it really, again, depends on the person. So I would say in my practice in general, someone has it for diagnosis. They have it again in 2 to 3 months to see whether the treatment we've started is working. If we have to adjust or change treatments, they may have it again in 2 to 3 months. And if they're doing great, then the next one kind of depends on the symptoms, but it might be a year, it might be 2 years. It sort of depends. Now, if someone has a stricture, and Eric, you can say, you may need to do 3 or 4 stretches over the course of 6 months or so to really start to get the esophagus open, and then monitor less frequently after that.
Yeah, yeah. If I can butt in, thanks, Dr. Dellon and Dr. Pandolfino. Um, it was so as Dr. Dellon said. Uh, yeah, the frequency of the endoscopies definitely have to occur, and this was something that was ordered on behalf of the doctor that did the surgery on my esophagus. And so when he went in, there was a 1.5 inch perforation of the esophagus. And so he repaired it with rib cage muscle from the back, and then repaired that hole, which caused the strictures. And definitely there's some scar tissue there from that surgery in 2017. So then he went a step further, the team, the gastrointestinal team went a step further, says like, well, how do we get here? Okay, even though you had these issues for like 15 to 17 years, how did we get to this point where your esophagus inflamed to the point where you had that narrowing where the pediatric scope couldn't get down your esophagus? Allergies. This is huge. This was a game changer for me because from birth, we feed our kids everything. We feed our kids eggs, milk, dairy, this, that, whatever. And so what did it for me was my team said, let's get you allergy tested. Let's diagnose. So that's when I went to another step and got a dietitian who says like, okay, what do you eat? I was like, okay, I eat everything. I eat pie, I eat cheesecake, I eat steak, I eat, I tried soy milk one time. Found out that was an anaphylactic trigger, soy milk. So then I went to a skin test, did a skin test. I don't want to go long-winded here, but this was kind of like, this was a game changer. I got tested for like, I did a skin test that did like, you know, they do the pricking and then your skin swells up. This was kind of like my baseline. Found out that I was allergic to eggs. Found out I was allergic to cow's milk. Found out I was allergic to almonds, pistachios, not all tree nuts, a few tree nuts. I was allergic to pineapple. I was allergic to apples. I was allergic. There were like 7 or 8 like baseline things that I took from this test where I was like, oh my God, I do get a scratchy throat when I eat apples. I do get a scratchy throat when I eat pistachios. I do get a scratchy throat when I eat almonds. I gotta stay away from that. My mom told me like when I was young, I couldn't do cow's milk for like the first 2 to 3 years. I had to do formula. This was huge, but over time, like Dr. Dellon said, we do adapt to things. And over time, I was able to drink cow's milk. You know, chocolate milk was like a staple. Chocolate milk before going to bed or after doing the workout because you get that protein build, you get this energy charge. I was like, wow, I can't do cow's milk anymore. So oat milk has been a staple for me now. This happened. I will say this. This happened after my second perforation. So I had a second perf after an endoscopy. This happened in 2018 after my surgery because they wanted to see how the esophagus was performing and what Luiz had talked about, the levels of EOEs in the esophagus. So we had to do endoscopy to find out the levels. My third endoscopy that was performed post-surgery or second endoscopy, I was perfect. I didn't know there was a perforation until I'm at work. I'm starting to get sweats. I thought I was coming down with the flu. Within 2 days that I had the endoscopy, my lung cavity swelled up like a balloon. And I'm like, what is going on? I thought I had pneumonia or whatever, because it was hard for me to breathe. I went to the ER. Sorry to get long with it. I went to the ER that night. They did an X-ray. They said, Eric, your lungs are filled up with fluid. And I'm like, how can this be? So they asked me, like, what happened to you like the last, 3 days? I'm like, I had an endoscopy 2 days ago. And they were like, oh my God. I had to go to the ER. I had to go to the surgery center. They had to basically poke my lung, drain it out. And then I know, and I'm not trying to downplay the endoscopy. I'm just telling you what my situation was because mine got to the extreme level. And we are here to talk about like how not to get to that extreme level. I don't want anybody to get to the level I got to get to, where you got strictures. It's so weakened that back there after post-surgery, you got to go back in, find out what levels of EOE. But it's probably too delicate to go back in there just because the strictures were just so crazy. So anyways, like this thing. Go ahead. What were we going to say, Doc?
I was going to say, yeah, I was just agreeing with you. We don't want people to get to that level. So I was nodding.
So now, fortunately, I've been great for 4 years. I'm actually going to go see my doctor that did the surgery next week and give him a Christmas card, in a T-shirt, because I told him he saved my life. He told me, he was like, Eric, there's no way that most people don't come out of surgeries like this. But after the Protonics and then after staying away from all my allergenic triggers, I haven't had an issue since. And this is after I had to do a hyperallergenic diet for 21 days after that second perf to basically get the EOE levels down to where it was comfortable enough where I felt like the esophagus I could swallow again without any issues. But I had to do a 21-day diet where it was a non-food diet, hyperallergenic. I lost 20 pounds, 30 pounds. But anyways, that was it. That's all I wanted to say about that. But I didn't want to downplay the multiple endoscopies to check out. But I just wanted to mention that, like, hey, if you're listening, don't get to the level where it's so severe where it could be beyond repair. Where, you get a pop, you get a perforation, and then you have to basically do a lot of damage control after that.
Yes. So, Dr. Dellon, Dr. Pandolfino, this allergen with EOE, that is actually common, right? So that is eosinophils are actually an allergic reaction. So can you just get really high level to our audience today a little bit about that and what they should be doing? It looks like Eric did a lot of sort of trying some things, doing the different diets and the skin tests. And he did work with a dietitian, and I understand that's key. Would you agree?
Yeah, so there's a lot, to unpack there a bit, but we do think EOE is an allergic condition, but it's different than the way you usually think about food allergies. This is not eating a peanut and going into anaphylaxis and shock. It's this delayed allergy that requires foods and the allergens in foods to be eaten over longer periods of time that start this kind of reaction. And because of that, some of the allergic symptoms that you were describing, Eric, like the tingling in the mouth after certain fruits or foods, those are more the immediate allergies, and EOE is a delayed allergy. And it can be very confusing because we don't actually have very good allergy tests right now to tell us what foods cause EOE in the esophagus. Most of the allergy tests tell us what cause immediate food reactions. And sometimes, many times actually, they don't correlate. And you got lucky, Eric, where they did correlate and you were able to find that. But many times now, we actually try to do have people avoid foods by having them eliminate the most common foods like dairy and wheat and egg and soy, nuts and seafood, regardless of what the test showed, because sometimes positive tests don't correlate and negative tests could still be triggers. So those are the empiric kind of elimination diets. And when once you're off of that set of foods that you choose with the your doctor and the dietitian, we would again repeat a scope and see if it's working to get rid of those eosinophil allergy cells. And then the goal isn't to be on a very highly restrictive diet forever, but it's to add back a food and repeated endoscopy to see if it causes those cells to come back to the esophagus. And if it does, we know those are triggers of EOE. And um, and if it doesn't, we know that's a safe food and we add a food back. And what can be tricky is that sometimes the foods that get stuck are not actually the foods that cause EOE. So, in your case, Eric, steak probably gets stuck a lot or did, and that's very rarely a trigger of EOE. But milk, which you drank constantly and would go down fine, is, a major trigger of EOE. And so that's why we don't always follow symptoms when we're looking at what the food triggers might be.
I just want to add two things. One, really quick, I did send my doctor as well a gift card and handwritten notes. After that. I don't know if you guys, the doctor said one too, but it was like a life-changing experience after I got this under control to the point I was like, oh my gosh, I need to thank this guy for taking care of me. And the other thing I was going to mention too, to Eric's comment, is that I am allergic to kiwis, strawberries, bananas, and I eliminated them completely because I never thought in a million years that I would be allergic to something as common as a banana. So and Dr. Dellon, to your point, I just kind of took one out at a time, and I noticed that after I did that, it was better because every time I did kiwis, almost immediately I'll feel I cannot swallow, and I gotta push it down. So I just want to add that for the people watching too, that those are my triggers.
And Luiz, you mentioned in your presentation about meat and that the meat was aggravating your GERD. That was one that's I had not heard before, honestly, when I watched your presentation. Is that common, Dr. Pandolfino, for GERD to be triggered, the reflux and the heartburn from meat?
And let me just add one comment. I'm 39 years old. Haven't eaten meat probably since I was 2 years old, because when I was young, my mom used to say that if she gave me chicken or steak or any kind of meat, I would almost immediately regurgitate. So I don't know if that's something that's my personal condition, but I never had meat, to the point that I don't care for it. I'm vegetarian for almost 40 years now. So
I think, well, there's two things that I would probably address specifically with this. One is certainly meat can cause reflux if it's fatty meat. So meat, meals that have heavy meat, heavy fat, can reduce the emptying in your stomach and increase acid. And that sets up a scenario where reflux is going to occur more likely. So certainly, yes, there is that part. The other thing too that you have to be concerned is, are you having these mild transient food impactions where you're getting a piece of food stuck, and that can actually feel like heartburn. It can give you chest pain, and you can regurgitate. So sometimes it could be actually a different presentation of a food impaction, and then people often confuse reflux with that. We tend to treat anything that happens above the diaphragm as reflux until proven otherwise. And we label it that way. And I think that's where kind of, being a little bit more proactive up front, figuring out what the problem is and treating people appropriately is, in my sense, a better model than just trying all these empiric trials, diet, medicines, and acids. It's just better to get the answer and to fix the problem.
That is great, John, because as we head into the last segment of this program, one of the things I wanted to ask both you and Evan are, what are some things that you want your patients, your first-time patients, to tell you? What are some symptoms that they might think, like Eric thought, well, this is just normal? But what are you alluded to a few earlier, John, but what are some really key things that if you're coming to see me and I'm a specialist, then these are the things about your life and your eating habits or your symptoms that it's important whether or not you think it is.
Well, I mean, I think certainly, the stuff that Evan talked about before is extremely important, because I will tell you that I've seen young people come in and tell me that they have no problems eating and they have a narrow caliber strictured esophagus. And I've literally said, okay, eat this piece of bread. And I watch them eat it. They dip it in water. They chew it for like 10 minutes. And they liquefy it in their mouth. I'm like, that's not normal. And if I would have asked them how often you're having a food impaction, how are your symptoms doing? They tell me, oh, I'm great. And I'm like, well, no, you're not. You've actually accommodated this lifestyle now, and that's just normal for you. So I think, one of the things that's very important for me, that when I see people, I actually watch them eat in my clinic. And, I actually watch them eat either a crack or a piece of candy or something like that. So that's something that's really important, I think, especially when you're dealing with esophageal problems. I always equate it to my students. It's like if someone comes in and says they're short of breath, you listen to their lungs, right? If someone tells you they're having trouble eating, you watch them eat. So that's something that I do a lot. The other symptoms that I think are very important are, how are you sleeping at night? Are you sleeping okay at night? Because esophageal problems can work in your sleep. How's your weight? Are you losing weight and not trying to lose weight? Those are important things. But the other group of symptoms too, that are maybe not symptoms per se, but more affect your quality of life, is, do you feel comfortable going out to eat with your family? Holiday meals, are you having anxiety around that? And really, that's something that we really focus on a lot. Is like, we don't negate the way this symptom affects your life, meaning that how it affects your social interactions with your family, how it affects your ability to work. Are you fearful that you're going to choke? Is that overwhelming you? So we try to also address the whole picture with the patient. And I think that's something that I always joke around. I say I'm a plumber. I come from a long line of plumbers. And I used to get mad because I couldn't fix people by fixing the plumbing. And now I know that half the battle is not just fixing the plumbing. It's also helping the patient feel comfortable living with the disease and understanding what the risks are and how they can live with the disease. And I think that's really had a major impact in the way I practice medicine.
Fantastic. Anything to add, Evan?
I really don't. It's a great summary. I think there's just a few other things for patients to know if they're going to see a specialist is make sure that all of your previous records, if you've had other testing, is available. If you've got a copy, bring it. You can't always trust the mail and faxes and that kind of stuff. And just be honest about your symptoms. And you're there seeing the doctor. if you're there and it's enough of a problem, that's our job to hear about it. And it doesn't help us if you come in and be like, I'm actually fine this week. There's nothing to tell you. That doesn't get you anywhere. So keep that in mind as well.
Yeah. Yeah.
Fantastic. So Eric and Louise, I'd like to end today by maybe you guys giving some of your thoughts to those out in the audience that might be suffering. There's some tips maybe of how you get through, or some words of encouragement for them.
Go ahead, Luis.
I would say, listen to your body. Like everybody says, if there is an issue, something's causing that problem. So go have a check. Don't think it's normal. It doesn't hurt. You may come out of that meeting with your doctor, knowing that everything's fine, but you may also be recommended to go see a specialist. And I think that both Eric and I can, we cannot say how much it has helped us to go through this process and find out what was wrong, because, it has changed our lives. So that's kind of my, recommendation here for everybody, young or old. You never know what's wrong with your body until you go check it.
Totally agree with Luis. Know your body, know the trigger signs. Even though this is a very new dynamic, it is definitely something that you don't want to overlook. I know with my story, because I think these panels are going to be great when you have doctors, specialist doctors, and then you have patients that have lived it. This is educational for people that may be having these issues. Someone out there that's listening to this is saying like, okay, this is me. I'm having trouble swallowing. I'm having this. And if you just saving one life is enough, and then there's your pyramid scheme of saving someone else's life before it's too late. I know I'm just a living witness that I'm able to tell this story just because of the perf that I had, and like the septic nature and having to go in. So just know your body. Don't be afraid to go to the doctor's office and be honest about what is going on in your life, especially when it has to do with eating food, which is so essential to the human body.
Fantastic. Thank you so much. You guys have been amazing today. I appreciate you taking your time to have this panel so we can have this discussion. I feel like we could probably talk for another hour, but I want to be cognizant of time for those listening, as well as for you guys who took time out of your schedule to be with us today. So Dr. Pandolfino, Dr. Dellon, thank you so much. I know you're very, very busy, and we appreciate all that you do for all of your patients and all those that are under your care. And for Eric and Luis, thank you for this encouragement that you're giving people, showing them that there is hope and that there are things that you can do to feel better every day, which is honestly what we all want, right? So thank you for your time and for sharing with us today. And I hope those of you at home have learned a little something. And please keep in contact with IFFGD should you have any comments or questions. And please watch the rest of the Norton Educational Series anniversary event, which is available on our YouTube channel at IFFGD.